Do you know what can turn that simple stomachache into something we call acute pancreatitis? Normally, it's not random. It's because of our daily habits. Around 80% of the pancreatitis cases come from two common habits: alcohol and junk food eating. Gallstones are the most common cause nowadays. They're generated by fatty foods and they block the drainage of the pancreas, generating that the pancreas begin to digest itself. This cause of acute pancreatitis is more common on women and older adults and persons that have any of the metabolic syndrome diseases. Alcohol is the second major cause, and is usually after heavy drinking about a long time, not just because of one night. The damage by alcohol is done by thickening secretions, blocking the ducts, and activating intracellular pathways that lead to the activation of the enzymes, and again, the pancreas begins digesting itself. This condition is more common than you think. It affects up to 20 people per 100,000 every year. It might sound like it's not that much, but it truly is. And it also is responsible for around 200,000 hospitalizations per year in the USA.
What if that stomach pain isn't random and your body has been warning you all along? Because acute pancreatitis doesn't just happen. There are real risk factors that silently build up over time. The biggest one, alcohol use, smoking, and gallstones. But that's just the beginning. High blood fats, certain medications, infections, even genetic mutations can trigger inflammation inside your pancreas. Even medical procedures or abdominal trauma can set it off, making this condition more unpredictable than you think. The most common symptoms is abdominal pain, constant, severe, often in the upper abdomen radiating straight to your back. It gets worse when you eat or lie flat, and the intensity doesn't always match how serious the disease actually is. You may also have nausea, persistent vomiting, fever, and fast heartbeat, but vomiting doesn't relieve the pain. In serious cases, it makes your body shut down, affect important organs, or even happen without pain, which makes it more dangerous.
What if your pancreas isn't just inflamed, but literally digesting itself from the inside?
It starts at the cellular level where calcium signals that normally control enzyme release spiral out of control. Instead of being safely released, digestive enzymes get trapped and activated inside the pancreas itself. Trypsin activates prematurely, triggering a cascade that turns powerful digestive enzymes against your own tissue, leading to autodigestion of the pancreas. The damaged cell will release inflammatory signals, recruiting immune cells that amplify the injury even further. Caused by a gallstone, blocking a duct, or alcohol toxic to the cells. The disease progresses in phases, starting inside the cell, spreading through the pancreas, and then exploding into a whole body inflammatory response. Once systemic, it affects organs like the lungs, kidneys, and brain, leading to respiratory failure, kidney injury, and inflammation disrupts blood flow, causing fluid leaks, poor oxygen delivery, and dangerous drops in blood pressure. This is why acute pancreatitis isn't just local, it can become life-threatening fast.
How do doctors actually confirm the diagnosis? It's not a guess. There are three key criteria. First, it usually starts with sudden and constant abdominal pain in the upper abdomen that often shoots straight to your back. This pain is often intense and comes with nausea and persistent vomiting. According to the major guidelines, doctors need at least two of these three findings in order to confirm the diagnosis. Second, blood tests, especially lipase, which are more accurate and stay elevated longer than amylase. If these enzymes are three times above the normal, it strongly supports a diagnosis. Third, imaging like CT scans, MRI, or ultrasound showing inflammation, swelling, or fluid up around pancreas. But here's the key: imaging isn't always needed if symptoms and labs already confirm the diagnosis. Once diagnosed, the next step is finding the cause, because treating the trigger prevents it from happening again.
But what's going to happen with my patient? He going to live or maybe not? Actually, the mortality is very low, just 1 to 2%. But be careful, because this can change in severe cases. But how will I know if my patient is a severe case? Well, using the SIRS. This helps us to measure the systemic inflammatory response syndrome. That if persists for more than 48 hours in one patient, well, we have a severe case, and the mortality increases to 25%. We also have BSAP, that help us to measure the mortality in our patients on the first 24 hours. BSAP check the boom, Glasgow, Sears, age, and pleural effusion. If our patients have 3 or more of these features, the mortality increases to 15%. If we have boon and hematocrit up in the first 24 hours, this can help us to predict multi-organic failure.
If someone is diagnosed with acute pancreatitis, what actually saves their lives in the first 48 hours? Treatment isn't just medication, it's about rapid decisions to prevent organ failure. First, doctors assess severity to decide regular bed, monitored unit, or ICU. Simple markers like high BUN, an elevated hematocrit, or systemic inflammation can signal a dangerous course. The most critical step, early IV fluids, started within 24 hours to prevent pancreatic damage from poor blood flow. Fluids like lactated ringer are preferred because they reduce complications and stabilize the body faster. Then comes nutrition. Early feeding within 24 to 48 hours protects the gut and reduces infections. In severe cases, feeding through a tube is safer than IV nutrition and lowers the risk of organ failure. Antibiotics are not given routinely, only if there's infected necrosis or strong suspicion of infection. Treatment is all about timing, early fluids, early nutrition, and the right intervention. If symptoms appear, go see a doctor.